Apologies, team. We are starting in a few. I can see posts on the chat. We are wondering, participants are wondering whether we are still on. Yes, we are on. We are starting in a few minutes. We are waiting for some of our colleagues to join. Then we can begin. Apologies for the delay, but we should be able to begin in a few. Yes, good afternoon all. Yeah, I think we can start. Just give me a second. Yes, so let me take this opportunity to welcome all of us into this call. Apologies, I think we have spent a few minutes waiting for a few of us to join so that we can begin. So as our tradition, I want to request one of the participants who has the mic to pray for us kindly, a volunteer among us, the participants with the mic. Kindly. George Mochama, kindly pray for us, please.
Let me pray. Let's believe and pray. Dear Heavenly Father, thank you for today. Thank you for this meeting that we're about to begin. Even as we start this meeting, start with us, and even as we end it, also end with us. I pray that we'll have some really good exchange of discussions, ideas in terms of just how to manage care for all the people in this program. And I pray that you guide us. In Jesus' name we pray, trust and believe it. Amen.
All right. Thank you very much, Cosmas. Again, let me just take this opportunity to welcome all of us into our webinar this afternoon. We'll be focusing majorly on some analysis that we were able to do just to identify where we have gaps in as far as viral load is concerned. Of course, this is more like a rallying call for us to be able to improve on our documentation and provide optimal services to our clients. And we'll be focusing majorly on analysis around monitoring the third 95 using individual data from the National Data Warehouse. Of course, matching that data with what was extracted from the EID and viral load database. So because of time, my name is Franklin Songok. I work at NASCOP. I know we may not really give an opportunity to all of us to introduce themselves, but I would request that we can utilize the chat box. But then again, I know before we join the call, you are required to register yourself. So again, we already have your details. So yeah. At this point in time, allow me to welcome Dr. Lily, who is our Ed Siri, to Ed SI, to make a few remarks, and then welcome the other leaders who are in the call. Then we will go to our agenda. So Dr. Lily, over to you.
Yeah, thank you, Songok, and thank you, team. Good afternoon. I see we are full house. Welcome to this webinar. I think as Songok has mentioned, and we also did include that in the webinar. Songok, I hope I'm audible.
Yes, Doc, you are very audible. Can hear you.
Yeah, thank you. So as I was saying, this is a webinar that is targeted to people who provide services to the HIV clients, either at facility level or provide oversight at county level, or our partners that also complement the work that we do. So we are here to disseminate to you, focusing largely on the third 95, because as you are aware, I think the viral load testing has been made largely available to our patients, but we are still seeing challenges in uptake and ensuring that we are ensuring that all our clients are getting viral load when needed as per the guidelines. We are still seeing that there are some of the clients that are coming, interacting with the system, but still living without having gotten a viral load test, which is very important in terms of supporting clinical decision support. So we are here to really discuss what could the challenges that we could be facing in terms of ensuring that our clients are getting the viral load, and then how do we move forward? I think the key thing here is how do we move forward to ensure that we are not having these missed opportunities at both at facility level and even at the site, at the point where we are providing oversight. So with those very few remarks, I think we shall continue to interact in the webinar. I hand back to Songok.
Yes, Dr. Lily, thank you very much. I'd requested that you welcome Dr. Ross, the head NASCOP, to just make a few remarks, and then welcome the other leaders. I've seen Brian is in the call. So just to give them time to also.
Okay.
Yes.
Okay, yeah. So our head is here. She's been very key in also just, really giving the viral load bulletin some extensive review and asking us very hard questions about what we are doing and the support that we are providing to the facilities. So she's very instrumental in this meeting. Dr. Rose, karibu sana. You make your remarks and also invite our other guests. Dr. Rose, did you hear me?
Doc, I can't see her. I don't know whether she may have dropped. I know she had joined in using my name. I'm not seeing her on the call. Yeah, Dr. Lily, I'm not seeing Dr. Rose. Probably maybe you could reach out.
Yeah. So, yeah. I'm trying to reach her. Actually, she had indicated that she's on the call. maybe we can have Brian make his remarks as I look for Dr. Rose. Brian, karibu.
Great, Asante. And thank you everyone for joining. As mentioned, we identified that there was an issue with the third 95. And as we were looking at the data, we also saw that there really was some significant variance between the counties and at lower levels. And we really wanted to explore that to see, were there some best practices that were coming through? Was this just commodities issues, and where there were commodities we were doing well, and where there weren't commodities we were not doing well? I think it goes probably beyond that though, and so that's why we really wanted to sit down and explore this a little bit more in depth. So I don't want to belay too much, and I want to get right into the data myself, but I do just want to thank everyone for coming together on this, because it is a critical issue for us to be able to hit epidemic control. When we looked at our numbers coming into the COP this year, we could see Spectrum is telling us that we're pretty much there for epidemic control on the first and second 95s. And the third one is where we're just lagging behind a bit. And so I think we need to now get past and really understand that and hit this and make some changes to get to epidemic control. So thank you, everyone, and looking forward to seeing the presentations.
Yeah, thank you, Brian. I see Dr. Rose is now back. So Karibu Daktari, as I had mentioned earlier, I'm not very sure whether you had, but we are a big team of close to 400 people, both healthcare providers, partners, and the oversight team at county and sub-county team here to discuss on the third 95. We've had several meetings prior to this one, and I know you've been very keen on the information and the support that we are giving to this team here to ensure that we are strengthening the third 95. So welcome, Doc, to make your remarks.
Good afternoon, everyone. And thank you, Brian. Thank you, colleagues, for joining the call. I want to join the appreciation that we have with Brian on the SI team for really looking at this issue of viral load. Once again, as many of us are familiar, in every season of HIV response, there's always been the goal and the purpose for which a program must live. And I think our value add for the HIV program today is really to push to a quality program where we have viral load suppression at community, at facility level, because now we have enough evidence and science to show that when we have undetectable viral load, we are pretty much sure around prevention of new infections, and also, the assurance of a stronger immune system and a quality of life for the people living with HIV and the clients for which we program. And as mentioned, the conversation now globally is our difference in programming is really on viral load suppression. We are really headed to a point generally in the population where we see reaching the 95, but our last 95 in terms of viral load suppression is not doing very well. In the recent IIS, that was a huge conversation, at the global scene around viral load suppression and what we need to do as programs. And of course, it starts by us looking at our own data. And so for the SI team, I just want to start by appreciating, taking time to look at where we are at this, so that we look at what we need to do together as we move forward. Apart from looking at what we need to do together, is really to also identify ideas and, those who are doing well to share with us. And lastly, is, as we sit in this conversation, is to really try to understand from the programmers and the people really on the ground, what are the challenges? Because perhaps we could be seated here and assuming certain issues, but there could be real issues that we need to appreciate to be able to deliver on that third 95. I say this with absolute confidence that this is one of HIV response in this country is one of the unique programs where there the cost at the client level or at facility level is minimized by the fact that we have a shared partnership with Global Fund, PEPFAR, the UN, and other agencies to really ensure that we have a strong pre-finance, for lack of a better word, of things like commodities, things like M&D systems, and things that support service delivery at that level. And we appreciate the counties and the government for, even the healthcare workers. So when you have a kind of a program like that, compared to other programs that may not even have the commodities, you want to anticipate that there are operational things that can be arise from the point of this is a financed program. What are the actual reasons why we would have certain gaps that we see? And we don't want to be blind to the fact that there could be realities on the ground. There could be tweaks that we need to do. So I want to invite us to look at this from a collective point of view. That is it that there are areas we are not investing properly where we see gaps, or is it that we are not sharing some of the best practices and maybe create an opportunity to improve at that? Because I do believe that all of us on this call have a shared goal to really push this program to a better level. And so I'm looking forward to the insights and the conversations around that and how we can move forward the program generally, but also for specific areas that we'll identify as gaps for a better program. So over to you. Thank you. Dr. Lily, am I still on the call?
Yes, Doc, you are.
Oh, sorry.
You are on the call. I don't know that Dr. Lily can hear us.
Yes, I can hear.
All right. So Dr. Rose is done, so probably maybe you could take it up. Okay, so thank you so much, Dr. Rose, Dr. Lily, and Brian.
Maria? Am I audible?
Yeah, we can hear you now. Proceed, kindly.
Oh, I've been talking all this time alone.
Yes.
Okay.
Yes.
This thing that I really appreciate, Dr. Rose, around the assumptions that we could be making at national level, and hence the reason for creating these opportunities. And there are many more that we really want to ensure that every time we are building capacity, we are providing feedback, and we are also learning from the people that are doing, well. So I think with that, we want now to move straight into the presentations, I believe, Songok. So I hand it over to you to organize them. So we have several presentations, right? We have the presentation on the viral load uptake and, highlighting the missed opportunities. We'll also be just giving updates around the database. And then finally also get to hear from one or two facilities that are doing, well, in terms of what it is they are doing for us to be able to scale up and also to just take that up to our facilities. So over to you, Songok.
Thank you very much, Dr. Lily. I think you've already covered in a nutshell what we'll present. So I really don't want to belabor by taking us through the agenda because of time. So at this point in time, allow me to welcome Mudoka to take us through the first presentation on the analysis that we were able to do, just covering the key findings, the results, conclusions, and some of the recommendations that we've made. And we've provided, once after this call, we'll be able to share the bulletin where we have links direct to the facility level analysis and even to the National Data Warehouse. And this is basically for remedial purposes at the facility level. So Dr. Mudoka, over to you.
Hello, Songok. Confirm if you can hear me.
Yes.
Would you want to split the screen on your side?
Yes, I can. Yes, I can do that.
Thank you.
Just give me a few seconds. I can just put up my screen. There you go. Confirm if you can see my screen.
Thank you, Songok. You can put it on PowerPoint mode.
Yes.
Thank you, everyone. So I'll be taking the team through tracking of the third 95, and we just want to look at routine data from the program to see how we are monitoring the patients on ART in terms of viral load uptake and also viral load suppression. So next I'll talk about the outline of the presentation. I'll be one of the next 3 other presenters after this. So Songok, if you move to the next one.
Oh, I'm having challenges again. Sorry, I'm having challenges moving the slides. So let me just reshare again. Apologies for this. Just hit toggle to. Okay.
So as the slides come on, we looked at data from the national data warehouse and data from the EAD VL database to do a viral load monitoring analysis. So I'll be sharing the approach that we used and the findings that we found from this data. We'll also have a short presentation on the tools for viral load monitoring at the front line that the team can be able to use. Then we'll do a bit of demonstration with these tools. And just as a way of introduction, on slide 3, this analysis is influenced by the national guidelines, where we know the 2022 guidelines recommend routine VL testing at 3 months after ART start, and then 6 months after that. And then for those who are young, up to 24 years, then 6 months every 6 months, then that's the routine viral load, and then annually for the older population. We know data from the EMR is sent to the national data warehouse and forms a rich source for tracking progress towards the UNAIDS 95. And today we'll just use this national data warehouse data to be able to track the third 95. We also know that there are digital health tools that we can be able to use to improve uptake of viral load and also track suppression. And today we'll present the lab manifest, the MLab and DMR, and how we can be able to leverage on this to improve these two. So allow me to delve into the details of the analysis. So this analysis is based on patients who are current on treatment at the end of June 2023. We looked at viral load based on data submitted from the EMR to the national data warehouse. And we also compared this with the data that is available in the viral load database. We looked at eligibility using the 2022 guidelines, meaning someone was eligible if they were on treatment for at least 3 months. And then for the 2 age categories, we looked at uptake for 6 months, as mentioned earlier, and annually as age appropriate. So 6 months for 0 to 24 years and 12 months for those who are 25 and above. We also used the new guidelines recommendations for viral suppression as a cutoff of less than 200. So straight into the results, I will share the cascade for uptake, and the TX car from all the EMR facilities was 1.2 million. 98% of them were at least on treatment for 3 months and above. And when you combine the two databases, the viral load database and the national data warehouse, 83% had a valid VL. And this indicated that 17% were due for viral load and did not have a viral load. And this translated to about 200,000. And when you compared with what we have in the national data warehouse, we noticed a gap of 2% of documentation in the EMR, which would have been uploaded into the national data warehouse. So in terms of scaling up uptake, we have 17% of patients who should have had a viral load, but did not have a viral load as recommended in the national guidelines. And the number was higher in the national data warehouse because of the 2% documentation gap. We looked in this documentation gap and uptake by sex and age in the next slide. And we noticed some age and sex variations in the viral load uptake. We see the first graph on your far left that males from close to 400,000 that 19% did not have a viral load as expected, because the uptake for the combined database was 81% and a 2% documentation gap in the EMR. The gap is slightly lower for female patients because the uptake is 84%, meaning 16% did not have a viral load as expected. And then for adults, the gap is similar to the other population, with 83% having a valid VL and a VL documentation gap of 2%. And we can say the uptake here is 17%, meaning 17% of patients needed to have a viral load, but did not have a viral load. When it comes to children, there's an even bigger gap in terms of viral load uptake, because only 75% of the children had a viral load based on the guidelines. And therefore, we had a gap of 25%. And also similarly, there's a bigger gap in terms of documentation, because 3% of viral loads that were found in the EAD VL database were not documented in the, were not found in the national data warehouse. So all this, the documentation gap is higher in males and in children. We also looked at data from January to June, and what we saw is that VL uptake has been increasing from a low of 65% to 83% in June, which is a positive trend. And in the national data warehouse, this has been slightly low by an average of 2% across. So what we did for this particular analysis, we just looked at the data that is available to see those who are eligible for a viral load and then the valid VL in January and the respective months. And overall, we see a positive trend. So hopefully if this continues, then we'll be able to bridge the gap, but this needs to be accelerated because a huge population at 17% do not have a valid VL. We can look at this documentation gap broken down by county and partner in the next slide. So here, what we have done is to look at the TX curve, those who are eligible for viral load, and then the viral load coverage by partner. And then we look at this using the two sources, the VL database and also the national database, and then to identify the gap in documentation. So even though the overall documentation gap is about 2%, there is variation in this performance across different partners. So when you look at the last column on your right on the documentation gap, you can see counties like Kiambu and Murang'a are among the highest in terms of contributing to the gap, from 11% to 7% going all the way. In the next slide, showing the second half of the counties that we have in the list. So if you move to the next slide, to counties like Uasin Gishu, Turkana, and Baringo that did not have a VL documentation gap. So the indicator of 0, it means that all the patients that had a viral load in the VL database also had a viral load in the national data warehouse, and that's a good thing. So the bigger the number, it means that there's a disparity, and the counties need to put measures in place to just make sure that those viral loads are being obtained from the national VL database and documented in the EMR, so that the patients can be able to benefit from that results. So similarly, we look at the VL documentation gap by partner in the next slide, and we presented this in just a graph, and you can be able to show counties like Migori CHMT or partners like Migori CHMT and USAID Marisha Jamii with 0 documentation gap, again meaning that all the patients that had a VL in the national database also had a VL in the VL database. And the increasing numbers all the way to LVCT PBT, it shows that there's a difference in terms of documentation, meaning that the VL is documented in the VL database, but it's not documented in the EMR and subsequently uploaded in the national data warehouse. So the goal here for this particular slide is just to identify places where partners may need to intervene to be able to improve on that. The second part of the presentation covers missed opportunities for viral load. So based on the criteria given before, is that we have a viral load uptake of 17%. And a viral load gap of 17%, and also shows that this 17% of the 200,000 patients came to a facility, meaning they came to a facility when they were due for a viral load and the viral load was not taken. So if this 17% could be able to have a lab test for VL done, then 100% of the patients would have a valid VL. We can look at this breakdown by county and partner. So again, using a tabular format for the counties, and what we have is missed opportunities on the far right. We used percentages and all that this descending to be able to indicate the magnitude. So in counties like Turkana and Bigori, again, the highest missed opportunities, meaning there were 3,900 patients who were currently on treatment. They came to the facility, they were due for a VL and the VL was not taken. And this represented 49% of patients who are eligible for a viral load. And similarly, you can be able to look at it across the counties. In this first half of slide 1 of 2, from a high of 49 to a low of 15% in Embu. And then when you move to the next slide, again, around 15% in several counties, including CI and Meru, and then a low of 5% in Kirinyaga and Nyeri. So a low documented or a low missed opportunity means that most of the patients who came to the facility received the VL as recommended for in the national guidelines. We look at these missed opportunities again by partner in the next slide, presented this in a graphical format. So county partners like BOMU, hospital-affiliated sites, only 4% came to the facility due for VL, and the VL was not taken, to a high of 49% as shown there. And I'm sure this is visible to everyone and you can be able to identify. So being able to provide a line list of this by facility level to just identify the facilities that may be contributing to this, and then the team can be able to look into how to be able to mitigate this gap. So allow me to move to the last part of the presentation, which is on viral suppression. We used a cutoff of less than 200 for patients who are current on ART at the end of June. From this chart, you can be able to see that the younger populations had viral load suppression of less than 90%, 82% for 1 to 4 years, all the way to 89% for those who are 20 to 24, the younger population. And then the older population from 25 years, that's when it's averaging to the national average of around 92%, all the way to the older population. So clearly the younger people have a lower viral suppression compared to the older population. The bars here represent the numbers, and the bars here represent the number of people who had a valid VL, to just give you an indication of how many people had a valid VL. And then these dots and percentages just represent the number that is suppressed. Then you can be able to see the inverse of the viremia in the subpopulations. Again, we've been able to do this by age and sex across in the next slide. To just see whether there are age and sex differences. And largely in most of the subpopulation and age groups that we have used here, the suppression is slightly lower among males, not by a big margin. In most cases, just around 2%, except the 20 to 24, where is around 3%. In other age groups, especially in the older population, there's not much difference between suppression between males and females. Again, we show the suppression by county and also by partner in the next slide. So the highest suppression from Nakuru County from a high of 96%, and it's quite similar across the counties. In this first set, up to Kwale at 93%. Just giving a moment for people to see and locate your county. And then in the next one, the bottom half, from 93%, very many counties, Kitui, West Pokot, to the lowest in Machakos at 81%. And also as in Gishu and Elgeyo Marakwet at around 89%. You can have a look at this, and then the slides are also provided to for you to be able to interrogate with the data, and also a facility level line list for the same. The last one is looking at viral suppression by partner, again from a low of 87% in CSHMT across to a high of about 96% in Bomu and Migori. And then you can be able to see the spectrum from where the other partners are in terms of viral suppression. Similar performance to what you saw in the counties. So in summary, VL uptake at 83% leaves a gap of 17%. And we notice a low uptake among children and males. And then there is a documentation gap of 2% for those who have data in the VL database, but not in the EMR. And we also acknowledge that there is an improvement from a low of 65% to 83% in June. And then there are very many opportunities. The patients are coming to the facilities. It would be good to make sure that these 17% do not have missed opportunities. Viral suppression is still below 95% target at about 92%. And we notice that it's much lower among children, adolescents, and young people. And you saw that from the results. So allow me to welcome Kote to just take us to the next presentation. Thank you.
Thank you, Dr. Mavaka. So again, thank you all for joining. I'll be just taking us through in terms of the tools that are available to be able to get these results. So look at, do you mind sharing the same PowerPoint, or you want me to?
I'm thinking you can share from your end, because you'll be doing a bit of, oh no, you're not doing, are you going to do a demo?
No, I won't do a demo. I just
okay. So it's okay then.
through the
It's okay then.
PowerPoint.
Okay.
Yeah, so as Songoke is bringing up the PowerPoint, so I'll be just talking about a specific tool that is there available for you to be able to use in terms of pulling viral load and EID results. And you can be able to, of course, document that for facilities maybe that are struggling in terms of connectivity. The tool is really friendly in terms of using it for SMS pulling of these results. So the tool is called MLab. And MLab in full basically is mobile laboratory. And again, it's a Android-based application. And also there's a web application. So Songoki, it's a web application and also an Android-based application. Again, it leverages, of course, on SMS that now you can be able to receive these results via SMS from all the national viral laboratories that do both VL and EID. Again, the main aim, the main purpose for this application is just to be able to see how we can be able to reduce the turnaround time from the time now you've already dispatched your samples to go to these testing labs to the time now you're receiving them back in the facilities. And again, the key point also is to make sure that it's confidential, secure. All the information that basically is being shared via MLab. If it's 2 SMS, the results are usually encrypted and they can only be decrypted within the mobile application itself. So I'll move to the next slide, please, Songok. So why do we recommend MLab? Again, like I'd mentioned within the introduction, is just to be able to reduce, of course, the turnaround time of the transmission of results, but also in terms of just matching of those results to the clients or patients during transmission. Again, of course, with this also, you can be able to see also some other kind of results that also MLab provides, which is to do with HTS. And these are mainly the PCR that are usually sent to NHRL. In case you've sent some of these for you to be able to get an inconclusive test that was done at the facility level, and you need more clarity. So when you send your samples, of course, to NHRL for the PCR HIV inconclusive ones, then of course you can be able to get those results within a short time around instead of waiting for the paper to come back to you. Again, also they are availed electronically within the application. And of course, this can be able to, of course, assist you to be able to get some clients back who maybe they're not doing very well in terms of their viral results that have come back. And of course, also, mLab provides also the patient notification feature that you can be able to also notify these patients the moment the results are ready and available. And of course, also we have the ability to be able to integrate with the Kenya EMR through IL for you to be able to also automatically pull these results. Next, please. So this is the base in terms of the process flow for mLab. Again, we have the process of where the patient is bled at the health facility. Again, we don't have any kind of interaction there because that is merely a clinical procedure that happens there. And of course, now once that has been done, the facility has the ability to be able to do sample remote login through the mLab application, which is a feature that if you've activated, you can be able to actually use that. Then of course, now that once that has been captured and the sample has been remotely logged in, of course, now there's the transportation of that sample, which again, it's not within the application, but of course it's structures that facilities already have. So once the sample, of course, gets to the testing lab, of course, it is tested and the samples results are actually entered into the NASCOPO VLEID platform or any other LIMS system, basically, that is at that testing lab. Then, of course, now mLab is able to pull those results using an API integration that has been done. So once those results have been pulled, we have number 4, where now the results are analyzed and categorized. And then, of course, now from there, now the clinician or the lab technician can be able, or any other person within the facility who is a provider, can actually be able to now use the mobile application to pull this as SMS within the application. That, of course, now at the same time, if they've taken through the patient in terms of them consenting to actually receive a notification for their results, the patient can also be registered, and now they can receive a notification. And this is what we are seeing at the tail end at number 6, where the patient can actually receive an SMS on their phone and just to notify them of their results are ready and available at the facility. So this is just a base process. We're just showing you in terms of a high level what happens behind whenever you're using the mLab application. Next. So how do you get mLab? At the end of the day, it's a good application, it's a good feature, a couple of nice features. So how do you get it on your phone? How do you get it to work for you? So again, it's hosted within the Google Play Store. Again, like I mentioned, it's an Android application. So it's hosted within the Google Play Store, where you can be able to just go and type in mLab. Once you've typed in mLab, you can be able to download the application and then start the process of doing the registration. Again, the most important bit that I have to mention is for you to be able to use the application, again, there's a facility mobile number that has to be registered within the web application. And this is something that can be supported through the partners, but also it can be supported directly through just calling our help desk at Palladium. And we can be able to, of course, also assist you in doing this. Once that is done, you can use the mobile number to be able to register. You input the mobile number. And then other details that are captured. Then, of course, now, once that is done, you can now be able to start pulling results from the mLab application. Next slide, please. So on this slide, we can be able to see what the clinical team can actually be able to do. So upon, of course, successful registration, as the various 2 screens are showing you, the clinical team can actually be able to pull historical results. Historical results mean that you can pull it beyond the period maybe you want. So let's say, for example, you had results that were maybe you feel that there are some missing results that you want to view sometime maybe in 2021 or 2022, for example. You can actually be able to use the application to actually do that, and it will be able to pull for you those historical results. Then, of course, you can also be able to pull specific patient results in terms of just to show you a trend. of this patient in terms of how many results have you done for this patient until now. So you can be able to also be able to do that and specify that patient by using their CCC number. Then of course also there's the highlighting of these results, where it will be able to highlight for you for a positive EID, to be able to highlight for you in red, just to show you this is something that needs attention right now. The same also applies for viral load, where of course also it will be able to highlight for you in also red, just showing you that this is something that needs to be taken care of for any high viral load. Then of course also there's the ability for you to be able to also print the results through the application, as you can see on the far right screen, where I've taken a screenshot where you can be able to connect it to a printer if you have a printer within the facility, and actually you can be able to print them out and of course attach this to the patient file. Next slide, please. So this slide basically shows us in terms of how you can also be able to monitor provider actions at an implementing partner program level, where basically you can be able to use the web application just to be able to see if results have come in within that facility, or if the results are actually available. Has the facility done the proper in terms of pulling those results? And have they pulled those results? Have they also read the results? As we can see in the next slide that Sungok will take us through, we'll be able to see where you can be able to see a timestamp where now, if the results have been pulled, you can be able to actually see a timestamp, and at the sent and delivered, it will be able to give you that timestamp and tell you that, yes, this is the time that these results were actually sent and delivered to that facility. And that is by the process of just pulling those results. Again, if that has been successfully done, the moment now the team there is able to click on any of the results on the mobile application, the application is able to send back the red timestamp. As you can see, the red timestamp reads unread, meaning that that facility has not managed to be able to actually open that specific result. So you can be able to actually just see what is that lag time between the time it was delivered or pulled and to the time now it was open for actions in terms of, and this is assumption. Assumption is that when you open it for you to be able to actually make an informed decision about the client and their care. So the timestamp for the red will actually become available at that specific moment. So in just to wrap it up really quickly, basically the application should be able to allow you at the facility level to really to get your the results as quickly as possible. But also at the same time, it should be able to allow you to be able to monitor for specific clients in terms of if they have their results have come back as high viral load, or for EID if they are positive. Easily you can identify that information easily just through the application without having to really go through the process of having to go peruse through other results. Again, also something to also really help in terms of monitoring at program level. You can also be able to see the utilization of these results by just looking at the web application and seeing how many have been read, how many of these results are yet to be read. And of course, you can be able to see them by classifications of whether it's high viral load or it's a positive EAD. So with that, I'll stop there and hand it back over to Songok. Thank you.
Thank you very much, Cosmas, for that walkthrough. So let me mention that the reason as to why we are taking you through these solutions is just to appreciate the power of digital health, so that we can leverage on them to try and ensure that this solution help us to reduce the number of the percentages in terms of the gaps. Because when you look at in other platforms, like for instance, if you look at the analysis that we've done, it clearly tells you that there's data on the other platform and it's not available on the other platform. But that doesn't mean that there's only one way of ensuring that data is available in the EMR. We also have other means of transmitting this data. So, and that's the reason why we are taking time to just share with you some of the solutions that we have that can really help in reducing missed opportunities and the gaps in our facilities. Right. So moving on, I want to welcome Kezia to take us through the next bit of the presentation. Yeah, Kezia, over to you.
Yeah, thanks, Sungok. Good afternoon, everyone. I'll be taking you through the lab manifest section. So we'll have a slide deck, and then later we shall have a look at these in the EMR. So just a short demo on the same. So lab manifest, it's a module we have in Kenya EMR that is designed purely to integrate Kenya EMR and the reference labs. It's built to enable facility staff to access electronic lab orders by having the clinicians, helping the clinicians to generate electronic lab manifests. They print laboratory manifests that accompany samples as they are being shipped. So I know we have, for the facilities that are not using the manifest, they do this manually. But if you're using this module in Kenya EMR, you'll be able to print your manifests as you are dispatching the samples. They enable them to remotely log in the samples instead of doing it again manually, and to seamlessly pull the results back to the facility, to the EMR, and have that result updated automatically to the patient record. Next, the value proposition for the lab manifest that we currently have is that it helps in reducing data entry burden. Before this, we would get a printout from the VLEID website, and then we would have staff manually keying in the results. This would have transposition errors and such, but now with an electronic one, we are assured that whatever results are coming from the website are the ones that are getting to the EMR and to the individual patient record. They are helping in improving the quality of the VL data entry and also the turnaround time. So we don't have to wait for all that time printing and getting the results updated. And then the availability of the results, again, it would be timely, because if a facility has internet connectivity throughout, then we expect that they will be able to get their results real time. Immediately they are processed and updated on the website, then the EMR would pull them immediately and have them loaded on the EMR. So if it's a clinician attending to that client, they will have access to their VLs immediately, and then they can make timely interventions. The other value that it brings to the users is on standardizing the sample labeling. So we have two versions. For those who are using a barcode scanner, we have that in the EMR, so you can just have that printed out, and then it makes the labeling of the sample very easy. Again, on unique identification, we had issues where maybe the patient ID would be incomplete, but now when you're using EMR, we are sure that whatever is recorded in the patient record or the CCC number is accurate, since we do not have any human interaction in updating the records. This is a flow diagram showing the process or how the lab manifest works. First, we need to have the clinician updating the order or lab order, which again moves to the lab staff, where the patient, now when they move to the lab, the laboratory staff will draw the blood from the patient, and then they will have to create a lab manifest. And this lab manifest will be updated with all the samples that will be dispatched. So a lab manifest is created at that level. And then once we have added all the samples that are to be dispatched, we can get a printout of that manifest. And then we have the samples transported to the lab. Then after that, once the samples are processed, they'll be sent, they'll be updated in the website, and then we will have that sent to the EMR automatically. So from the lab, there is the automatic transmission of the results to the EMR and the automatic update to the patient record. So this is just a simplified diagram on how the entire process works. So we shall be able to see this practically in our demo. In our next section, we are looking at the process that we undertake in right from when we are configuring the EMR to be able to communicate with the lab. And then we shall see the process in the EMR as we proceed. So the first on this slide, we have the configuration that we need to do before we even begin using the lab manifest. So this is a function that is performed by an admin at the facility. Could be the HIS contact person or a facility super admin who is doing this. So someone who has been trained on how to do the configuration. We use the developer app in Kenya EMR to do this. And it involves specifying the property values for either the child, labware, or EDAP endpoints. So there are a number of labs that we are covering or that are integrated with Kenya EMR as we speak. And I believe these are most of them. Maybe only one has not yet been fully integrated, but you can look at the list on these screenshots. And if your lab where you take your samples is not part of that, then you can link up with us. So KU is one of the labs that is missing, but we are in the process of integrating that. How to request for a VL in the EMR. So before you, for a sample, for you to be able to add a sample in a manifest, you must have active orders in the EMR. So how do we create an active order? You navigate to a patient record, then you select the lab orders, you update the required field, that is the sample that is being collected, the test that is being done, the reason, and then we have that saved. Next. Then the other requirement that is needed for that sample to be successfully added in the manifest is regimen line. So even before you navigate from the client to the lab manifest, we need to ensure that every client has a regimen line assigned. So how do we do that again? You navigate to the patient record, move to the chart, ARV regimen history. That is where you will ensure that the adult first line, you can see the highlighted fields on the screenshot. You ensure that all those fields are filled, and then you can proceed to the manifest. Next. How to create a new manifest, lab manifest in the EMR. You'll navigate to the lab manifest as highlighted on the screenshot, and then you click on that. And after you've done that, it will add you on the manifest summary page. So the down screenshot is a summary of the manifest where you'll be able to see those that are on draft, on hold, ready to send, and all those. Then on the next slide, we are continuing with how to create. You'll need to start by clicking on the draft and then click on add new manifest. And then on the down screenshot, the bottom here, these are the fields that are captured in the lab manifest. We shall be able to look at all this in the EMR. Filling the manifest, you can see on the screenshot, those are the areas that we need to ensure that they are filled. So ensure the start date and the end date, and those are the dates that for which the samples were collected. So there are facilities that transport or dispatch their VLs on a weekly basis. So we expect that this manifest will have days within that week, and then we will have all the samples added to this manifest. So we don't need to create for each and every day. We can have the manifests in one batch for that whole week until they are dispatched. So we need, when we create a new one, we leave it at draft to allow us to add on the manifest. So how do we add samples to the manifest? We already created a draft manifest. So and like we mentioned earlier, is that we need active orders. So we are assuming that we already have clients whose samples have been taken. The orders were created and their samples have been drawn. So what we need is just to add them to our manifest. So as you can see on the manifest, on the screenshot, you can see the add to manifest. So for those who have active orders and their samples have been taken, you just click on add to manifest. Next, once you have added all those samples to the manifest, and now they are ready for dispatch, we need to change the status of the manifest from draft to ready to send. So for the transmission to happen, you must change that status to ready to send, so that when you are connected to the internet, they will all be remotely logged to the website. And then you'll be sure that now what you'll be awaiting is the of results and the pooling of the same. Next. Viewing of the results once they are processed and are updated on the website. So remember, we created a manifest. When we have done that, there is a status on that manifest. So you need to check the status of the manifest. Under the manifest details, we have a status. So that tells you where you are on that manifest. Then if you need to view the status of the individual samples, you can see down here, we have samples in the manifest. So you can check result for each of the client or each of the sample that was sent. So if not ready, then it means it's not yet processed. There are those that you'll get the actual results, or there are those that you'll get as another status, and which will be defining in a few. Next. Yeah, to track a manifest, we have different statuses here, as you can see on the left. So draft, we started by saying, this is when you've just created a manifest and you are yet to update or to add all the samples to that manifest. Remember, we said we are working with a batch. So if it is a weekly samples that have been done and the dispatch is on Friday, then by Friday, it will still be reading draft. But once we are ready to dispatch, we change that status to ready to send. So our second status is ready to send. This is it's set when all valid samples have been added and are ready to be submitted. In some instances, we may put a manifest on hold. This depends with the facility, but it is because if they are, for some reason, the manifest should not be submitted yet. Then we have another status for sending. This is a manifest that is still on the process of submitting. You already changed the status to ready to send, and the process of submitting is not yet over. So it still will show you sending. Once that is complete, that is when you'll see a status submitted. All the samples that you had added have successfully been submitted. That is when you will see a status for submitted against that manifest. We have another status for incomplete with errors. So for this, it has some samples categorized as incomplete by the lab. So yes, we sent from the facility, they go to the lab, but for some reason, they have been labeled incomplete with errors. So for such a scenario, in Kenya EMR, we have a button for reprocessing, so the facility staff can reprocess the same and have it resubmitted. We have incomplete results as a status, and this again shows a manifest where some samples have pending results. We have received results for some. Maybe you had 15 samples in that manifest. Then you only have 10 results back. So for results for 5 clients are not yet back. In that, you'll find the result for that manifest is incomplete results, meaning we still have to wait for the other to be complete. Then we have complete with errors. This is a manifest that has some samples results not saved in the EMR. It could be due to the format of the result or any other reason. You have received all the results, but for some reason, some results were not saved in the EMR. So again, we have availed a button for reprocessing to try to keep on trying to get these results right. For our status complete results, this is where all the samples that we submitted, we have also received their results completely. If we had 10 submitted, we have received 10 results for our clients. That is why we are marking it as complete results. So these are the various statuses that we have in the manifest. I hope from now we will be able to interpret them accordingly. Next, it's how we review the unprocessed samples. So in the process of sending, all samples that need to be collected again will be available as part of the results that we get from the lab. If maybe a sample was rejected, then the result that we'll get is that we need to collect a new sample. So we have availed a section where you can find all those samples that were assigned, that the lab recommended a new sample to be collected. And then we have all missing samples that did not reach the reference lab. So sometimes you find maybe a sample was added to a manifest, but maybe the sample was not part of what was dispatched. So in that case, we'll find a result that says these samples missing in the lab. So we have on the screenshot, we have the two, and these need action. So you'll be provided with the samples that had issues where we need to collect new samples. And that's why we have this section to access those and have the necessary action taken. A note is that unprocessed samples or samples without results with feedback from reference lab should be actioned accordingly. So whenever you find some samples listed under the two, you need to make sure that the necessary action is taken. Next. Yeah, this is showing the uptake of lab manifest by county, and you can see the distribution. Nandi being the best. You can see up to down here we have Baringo, so you can see uptake of lab manifest across the counties that we support, and you can see where you are as a county. I believe we have the county representative here, so we can change the story and ensure that we are fully using lab manifest in our counties. Then next we have the same, but now by partner. So again, for the partners represented, you can see how you are doing on the uptaking this. And again, the aim is to ensure that our partners support these facilities to have the configurations that are required done, and then mentor the facility staff to ensure that they know how to use the lab manifest and follow up to ensure they are well supported. And in cases where you have issues in configuring or using this, we always have our service desk on. Always reach out to us and we'll be able to support. Next. On this slide, or in the next few slides, we are looking at the reports that we have in Kenya EMR that will help us in checking or assessing where we are in viral load coverage and uptake. To start with is a facility dashboard. And this is usually our landing page. The moment you log in Kenya EMR, the first thing you'll see is the facility dashboard. And there you will be able to tell the total clients with VLs in the last 12 months. So we are just looking at the valid VLs, and then total unsuppressed, how many are those? And then total suppressed. So where we need to emphasize more is those with unsuppressed results. What are we doing about those? What are we doing to ensure that they reach suppression levels? And then if our TX-CAR, if this is not the complete TX-CAR, could be you have 800 clients, but you're only seeing 633 here. We need to ensure that all our clients have a valid VL. Next, we have another report that will help us to just keep on us checking how we are doing. We call it viral suppression report for current on ART patients. So what this will give you is a summary out of your TX-CAR, how many clients are suppressed. That is what the first indicator will show you. And see for this facility, if it was a real facility, they have 617 suppressed out of the TX car, 30 are unsuppressed. Out of the TX car, 106 have no valid VL, and 36 have no VL. So where do we need to put more effort? On the unsuppressed, on those with no valid VL, of those with no VL completely. So is it that there is a blocker, or is it that we have not updated these in the EMR? So for the unsuppressed, if you want to access the list of 30, you just click on this number. It gives you a line list of the 30 clients. So depending on the interventions that need to be done, you can have that list and maybe assign case managers, call these clients to put them on support groups and such things. For those with no valid VL, could it be that we have the results in the website, but we have not updated them in the EMR? And we have said that we can avert this by using the lab manifest, and then have internet connectivity so that automatically we get these once they are processed. For those with no VL, unless it's the category of people who are not yet on ART for 3 months, then we should ensure that we have everyone with a VL and a valid one. Next. We have another report that we call clinical action report. And this, we say it's the one-stop point where you get the program gaps, all the gaps that we need to work on. It gives you all that. You can just look at the indicators that we are capturing, but the highlighted part is where we are looking at VLs. So the first one is those without valid VL. We had already seen this on the previous report, so it's the same. Those with unsuppressed valid VLs, again, we need to action. For those unsuppressed with invalid, they were previously, they do not have a current VL, but they were still unsuppressed the last time we had a VL. So these are areas we need to check just to improve our VL uptake and coverage in the journey of getting towards viral suppression for all our clients. So apart from VLs, this report will help us in so many ways in just identifying where our gaps are and where we need to action. UI meetings, this report will be very important for us. So having said that, I'll quickly just show what we have, the same that we've gone through in the EMR in few minutes.
So, yeah,
yes?
as you prepare to share your screen, I'm kindly requesting that you may need to, you may need to summarize the demo bit because we still have another presentation to make from LIT, and we also need to hear from the two facilities on their best practices because of time. I can see on the clock we have about 30 minutes to four, and I also want to appeal to the participants that we may stretch a bit because of that. So kindly be patient. We will stretch a bit beyond 4, but Kezia, kindly summarize so that we go to the next bit. Thank you.
All right. Thank you. In the spirit of saving on time, allow me to just use what is already existing. And maybe I can just start from where we began, ensuring that we have an active lab order. I won't key in any details, I'll just show how we do this. So I'm working with the client who already exists in the EMR to create a VR request order. You create a new order and then select the specific lab test that we are doing. So HIV, you update the dates when it was done, ordered, and then the reason why it was done. So having done that, the next thing we said we start by having an active order. Then once we have that ready, we need to ensure that our client has a regimen line updated. How we check that is by going through the chart, MOH 257, and then confirming that this section is updated. So if the last regimen doesn't have that is not assigned, then we need to update on this part. You can do that by undoing the last change and then updating this again, but now ensuring that we capture the regimen line. So this, as of now, for the clients that are starting ART now, It's mandatory, so there is no way you will change or start a new client on a regimen and then we miss a regimen line. Having done that, the next thing is on the lab manifest. To create a new manifest, we talked of starting by clicking the draft and then adding a new manifest. So these are the variables that we pick. We need to have updated. So you'll see some are already auto-populated from the system. And then you need, for all that have an asterisk, that is a mandatory field. So you'll need to have that again updated. So once we have a manifest done, we have these that had already been created. How do we add the samples to it? So when you click on view, you'll be able to see all the samples that are active and maybe were created within the period that we specified. So we can click add to manifest on this. Sample type, frozen or whole blood, the date of collection. So could be second, and the separation date. Once you've done that, you save. So that has moved, has been successfully added to the sample, to the manifest. So you will do that for all the samples that need to be dispatched. And once you've completed, again, we said you edit the manifest status from draft. While we are adding, it is on draft, but when we are ready to send, you click on ready to send. So once you've done that, if you have active internet connectivity, then all those samples will be processed and will be logged in on the website. So unfortunately, this is a test server, so we may not be able to see these other processes as they happen. And maybe what we'll now talk about is more on what next after that. We expect ready to send. We'll see them sending, we'll have them submitted. So on the submitted, we talked of the status. So this is already assigned, submitted. So what if we want to see the specific results for that? So you see, we have the samples that were under that manifest that were submitted. And then when the results will be ready, shall be able to access them here. So another important thing is for us, when we have added all the samples, or at any point when we need to print the manifest, this is where we need to, where we need to have the manifest to accompany our samples, Yeah, we have the labeling that we talked of. When you click on print label, this is the label that you get. So it already has the patient number, the patient name, and the date when it was taken. So this is where we're saying it is helping us in correctly identifying the samples. Then when we need to check on the entire or to print the manifest, then you can access it here. So this will contain all the samples that were sent. And these are the details that we collect. Most of them are collected when we are ordering for this sample. So we just pick from the patient record and have them updated here. So instead of doing this manually, once you use the lab manifest, you'll be able to print out this and have it accompany your samples as they are being dispatched. So we've seen how to get the results. I talked of those with the errors. Under this, if you have any that were incomplete with errors, we mentioned about reprocessing. So you'll get a button for reprocessing. So this being a test instance, and we do not have maybe an active lab instance, we may not be able to see some of the results. We talked of reviewing where we had actions required. So again, if you had any that needed a new sample, you'll have the list here, or any missing samples, you'll have it here. So using this, you are able to track your manifest throughout from the start, when they are draft, when we are submitting, when we are checking for the results, and now when we need to see a summary, we have this summary page that will show you the status of your manifest as a facility. So the other thing, we talked about the reports that are supporting us in VLs. I talked of a facility dashboard. So when you click on the facility dashboard, on the right, we have the tracker, the viral load tracker, and this is what you will see for that specific facility. And then we have the other reports. These are found under the common tab. We have the clinical action report here. So you'll just click on it and generate a report using the same process that we do. Define a period of interest. If it is July, you can generate that. And we already discussed on what we shall get under that. If you want the line list of those clients, you just click on the number, and then you shall get the list. Where you're guided on where to find the exact list, then you go back, you use the instructions provided. The other line list we talked of is virus suppression report. Still under the common reports, we have virus suppression report for current on ART patients. So again, the process of generating the report is similar. And once you have the report ready, you just click on the number to get to this view to see this. Then if you want to drill down further to the specific clients under that who are unsuppressed, you click on the number, it's a hyperlink. It will take you to the line list. So you have this list, which you can download and action accordingly. So those are the ways, some of the ways which we can use to just improve on our viral load tracking and management. So due to time, allow me to stop at that point. Thank you very much. Back to you, Sambok.
Thank you. Thank you very much, Kezia, for the walkthrough and more specifically the demo, so that we can be able to relate with what you took us through the slides. So I really don't want to belabor so much on what Kezia has taken us because of time. I want to welcome the Health IT team. So in the spirit of collaboration and integration, we know that Health IT is a partner that is supporting the EID and viral load database, and that is where all of us access EID and viral load results. So there've been a lot of work that has gone into that, and they've been working together with NASCOP and Palladium to also ensure that the data that is available there is clean. And in fact, with the analysis that Palladium shared with you, we work together, NASCOP, Health IT, to be able to pull that data, run the analysis, and do the matching. And this, whatever results were shared was very, very collaborative with the teams working together. So in that spirit, I want to welcome FIT to share with us the kind of enhancements they've been able to do, basically to also help in facilitating data exchange with other systems, National Data Warehouse and the other system, I mean, Kenya EMR or other EMRs and any other system that we do have. So Moses and Tim, if you can hear me, I don't know if it's Moses or Simon who'll be able to make the presentation. I know you had challenges earlier on. I don't know whether you've been able to join, and I'm not sure that you have a mic. So kindly raise your hand so that I can make you a co-host. Apologies. All right, thank you. Right. Yes, so Simon, go ahead. Just a minute, Simon. You need to raise your hand again. Okay, Simon. Oh yeah, sure. Sorry. Sorry for that. So Simon, you can go ahead and mute. Moses, I can see your hand is up also. So let me just Yeah, so over to you, Moses. I don't know that you're starting.
Yeah, thank you, Songok, and all the participants in this meeting. So in the next few minutes, we'll have Simon take us through some of the enhancements that we have made on the EADVL system. Most of the work that has been presented by colleagues here, Dr. Muthoka, Kezia, and the MLab, they link to the EADVL system in terms of submission of manifests and also pulling data for use in the different systems. So Simon will be highlighting those enhancements as well as part of the alert system for critical results that has been implemented for purposes of enhancing follow-up, especially for HAZE, to improve results for PMTCT, as well as tracking the unsuppressed clients. So Simon, please, if you are able to present your screen, take it up.
Thank you, Moses, and good afternoon, everyone. So
good afternoon.
I'll proceed and share the screen. That is for the element, for the components as indicated. So confirm you can see my screen. Anyone on the call?
Yes, I can see.
Sure, thank you. So basically on the EAD viral load database, we have made enhancements on three main components. That is on integrations. Then we have on the lab level websites where the facilities access to remote logs.
Simon, we cannot see the presentation. We can see your screen though. So you need to bring your presentation up.
Sorry about that. Let me reshare that.
And Simon, try to raise your voice a bit. Some participants can't hear you very well.
Okay. You can see my screen. The presentation, that is.
Not yet.
Drop it and try.
Kindly, Songok, if you can just present on his behalf and then he takes us through. We are still not able to see your screen, Simon.
Yes.
Your presentation rather.
Yeah, so I may need to just take a few seconds to locate the slide deck that has the consolidated slides. Sorry, just give me a few minutes. Simon, you can try as I look for the other slide. Kindly. Right, sincere apologies. Let me just quickly share. Someone confirm if you can see my screen.
Yes, we can, Songok. Thank you.
All right, so Simon, you can proceed.
Yes, thanks and apologies for that. So I was mentioning that we have three main updates we've done. That is from the integrations to the EID database, and yeah, we could just scroll through. Next slide. Next there. So we have done majorly integrations with the different applications. So we have the updates on the lab level LMIS, Lab Management Information System. That is what the facilities access to send sample requests. And then we have changes on the EID database, EID dash, where partners and facilities access results and also do patient follow-ups. And then we have updates on the integrations with the other client applications. So for instance, on the screen being shown, we have integrations with the Labware and CPIMS. We have integrations to Kenya EMR as well. So we have done some enhancements on those integrations to make sure that all the client applications are able to get results in a timely manner. That is the users who use Kenya EMR, CPIMS, Labware, and also those who query results via SMS are able to get the notifications and the results relayed within the minimal time possible. The next slide, you could just scroll through. Next slide, please. So majorly at the lab level, we have major changes on the sample requisition, and this has been informed by the 2022 guidelines that were published. And we have the tools whose revision has been now finalized. So we have made the adjustments on the EID website so that the requisition is based on the current or the final revision that was done on the tools that are yet to be are now accessible to the facilities. So to start with, on the EID sample requisition section, you will expect to capture a CC number in 2 bits. That is, you capture the MFL part of the CC number, followed by the second part of the CC number, which is normally the serial of the mother. That is for the mother information, you are only required to capture the mother CC number, and using that number, we'll be able to link up to get the mother previous last viral load from the database, because we have enhanced on the format of the number. So we are sure that when we go with this CC number that we provide, we are able to track or to get the previous results for the mother. And if the mother is if there is no mother, then you'll only provide you'll only indicate up here that it's a caregiver and proceed. So this change is accessible for the facilities who do remote login using the NASCOP website links. I think that's the main thing here. The next one, so on EID's requisition, we didn't have major changes or adjustment as per the last revised form. The only thing that changed is the format in which you capture the mother CCC number or the mother information. On this slide, we have the VL sample requisition where we adjusted, and the first highlight of the box, it shows a checkbox for which when selected, you get the rules on the page relaxed so that you are able to capture only the fields that are compulsory for recency tests. So for the facility doing an entry, a remote login entry, once you select that checkbox, you'll only be requested or required to provide the compulsory information, that is followed by the date of birth for the client, the gender, and then other details like, for example, date of initiation on ART will not be required. The CC number will not be a compulsory field. The same when the checkbox is not checked, you'll have to provide all the compulsory information for a VL requisition. So the next slide, we have the adjustment per the new guidelines 2029, as also indicated on the form that was published, was revised, I think last week. So the justification codes will include the ones that have been used. For example, you realize right now we have facilities who are currently collecting samples using the routine VL. So the justification codes will all be available. However, the numbering will be incremental as indicated on the last tool revision. So that means that for those that do remote in, we will have to adjust and pick the right justification when we are doing the sample entry. So for the EMR side, the same will be shared to the EMR team. I think the tool been shared. We'll be able to share with the EMR development the responding codes so that the revision from Kenya EMR, you are able to pick the right justification code. So that is the main change that you'll have on the VL page, the justification codes. The intervals for making the requisitions have been adjusted to 3 months as prerequisite for the first VL and follow-up as indicated on the guideline. The next one, the next slide, on the VL form, you realize we added a field. Next slide. The UPI, the patient unique number field. So the field basically is to help the person doing an entry at a facility level during remote login to be able to capture a valid patient record, so that when we have the data on the national viral load database, we are able to link that data with the data that is in the national data warehouse. So understand, right? So that will be the linking point between the two data on the viral load database and on the national data warehouse database. So providing that number helps in being able to track the client information. So when you provide the number and click verify, you'll be able to get the detail, the corresponding details of the client as submitted to the client registry. So if the information matches, you just click on use details and you'll be able to get the patient information section pre-populated on the request page. The next one on EMR remote login, I think that has already been mentioned. The scale up is now for all the labs support EMR remote login. So what you need is to liaise with the support partner to get the credentials. If you are not able to, you reach out to the lab or to the NASCOP technical team to be provided with the credentials. You could scroll through. Next. So on the VL dashboard, we have the user management component that we have worked on. So on the user management, we have added a component whereby every user is assigned corresponding counties of support or facilities that they support. So for the users, the different mechanisms, those users who need to access to the national EAD database, you'll provide your contact information together with the counties you support alongside the facilities, so that your account is mapped to the corresponding sites that you support and counties, so that you have access to the data that you need, the data that you are supposed to access, so that we avoid a scenario whereby a user accesses data for the sites that he does not support. So providing that information enables you to be able to get prompts or alerts whenever the results have been released or dispatched. So for every result that are dispatched, if you have been allowed to view critical results, that is for VLs and EID positives, you'll be able to get notifications for the counties that you indicated you support. So it's important for you to provide the correct information at that point. The alerts for VL, we have the critical alerts that are normally sent out will be sent out on an email in summary form. So for example, this is based on ranges, outcome ranges. So for example, above 1,000 copies per ml, above 200 copies per ml, that is 200 to 999 copies per ml. And the summary is generated per facility and shared to the contacts that have been mapped on the EID database. That is for patient follow-up and tracking. So the report is available to all partners, lab level focal persons, and facility users who indicate they need access to that summary. This slide shows the critical summary of the critical alerts. That is for the VLs. So it gives a breakdown of the clients, the age groups, the respective the facility, the county, and we indicate the date when the sample was collected and when it was dispatched. And also we indicate the TAT, the turnaround time in between when the sample was collected to when the results was dispatched and the corresponding results. So this information is shared with the stakeholders and both at national level, mechanism level, and to the county levels for follow-up for the clients who have high viral loads in that case. The next slide, on the VL dashboard, after the updates we indicated earlier on the requisition tools, we expect to show the summaries as indicated on the slide. That is the ranges, the cutoffs as per the 2022 guideline. And so that visuals, we'll expect them to reflect to this once we start collecting the samples using the new requisition tools. The next slide, please. So this is the test done per unique patient. So we pull data from what is submitted from the EMR vis-a-vis what we have on the NASCOP database and try to compare that data based on the reporting period. So is as indicated here. So we made an adjustment, and these summaries will be enhanced so that we are able to get to know those clients whom are expected to have been done a VL, but they haven't been done a VL as per those that have been reported on KHIS. The next one. So I think this is you could scroll through. Basically, these are just dashboards accessible to the public to show the status within the lab. But of importance is on this page. So the resources page, we will have the updated VL and EID requisition tools uploaded here. Once we have gotten the confirmation for implementation that is on the EMRs and on the NASCOP database, NASCOP lab management information system, the changes have been effected. So what we are looking up to is having the EMR, different EMRs implementing on their end, and then we publish or we make accessible all the requisition tools per the new guideline on this page. So the facilities will be able to come to this page and download the latest tools. And among the tools, we expect to get the updated EIDVL user guide, which includes the enhancements that have been done on the page. And also, if you could scroll to the next slide, on the resources, you will also get the enhanced lab user guide. That is, for example, for those of facilities which do POC testing, they'll be able to access a guide on how they can be able to test, to document the results, dispatch the results, and also track at their POC level. Then also have the training slides, which the mechanism of their partners who support facilities within the different regions will be able to access training materials that they can utilize when supporting their corresponding zones. I think that is it from my end. All the resources will be published on the resources page for access by the different facilities and users. Thanks, and over to you, Songok.
All right, thank you. Thank you very much, Simon, for the walkthrough. Again, because of time, I really don't want to belabor on what you've taken us through. I want us to just transition into the next level. And I hope by now, you understand the reason as to why we are really focusing on some of these enhancements, because we feel that it will really help us in reducing the missed opportunities in terms of documentation and exchanging data seamlessly between one system to the other. And I think one of the things that stood out clearly is that if we are able to standardize the way we capture our CCC numbers or our client identifiers, then that's the basic, the bare minimum in identification that would really help in exchanging data between one source or between one platform to the other. So at this point, allow me to just to welcome our two colleagues from the two facilities that I mentioned earlier on. We requested 2 facilities to present on behalf of the rest of the teams, that's Tumutumu and Mbagathi Hospital. So what we want to hear from them, basically, it doesn't really have to be a presentation, but what we want to hear from them is what is it that they've been able to do in their facilities to be able to ensure that their uptake is close or even above 100%, and they've reduced documentation gaps up to less than, actually for the 2 facilities, it's 0.2, and for the viral load uptake, it's about actually 99% for both facilities. So what we want to hear from them basically is just to tell us what are those unique things that they're doing, what are their strategies, what are their best practices that they've been able to do or been able to employ within their facilities, so that the rest of us can also learn, because one of the things that we need to appreciate is that it's doable. If Tumutumu and Mbagathi are able to do it, why not other facilities? So I think I had already allowed the two to be able to share with us very quickly. So, Charles, okay, so Charles, you can go ahead and unmute. Charles, go ahead.
Thank you, Songok, and good evening, everyone. I know you don't want a presentation, but just allow me to pull this up so that we can share what we are doing as Mbagathi.
All right, go ahead, Charles.
Yeah, so for us as Mbagathi, we decided to look at our problem in the lens of quality improvement. And when we looked at our data in FY21 Q4, we realized that our uptake was only 38%, where we had bled 2,000 clients out of the 4,572 clients, and only 1,728 had documentation within the EMR. So what we did, we looked at it through the lens of root cause analysis using the fishbone, and some of the gaps that we identified within the team were some of the clinicians were not putting up the lab orders. We didn't have somebody responsible just to update the results in the EMR. And then we didn't have that SI clinical interface well connected, whereby we could have a line list to track from the EMR. And then at that time, we had inconsistency with the supplies of PPT tube. Then we also had some long turnaround time for viral load results. Then we also realized that some of the clients were put on multi-month dispensation, and some were using to pick drugs over the weekend. Then also it was the period post-COVID where we had irregular school calendars, and also it's the time where the ART guideline had just changed, and some of the clients now are eligible after 3 months, then the 0 to 24 after 6 months, then the adults after 1 year, which really kind of affected the uptake. So what we did for the team, first we sat as a team to discuss during our facility data review meeting, and we decided to generate line lists for those that were eligible for viral load, just to try and optimize the use of data for the decision making, and also utilizing the line lists available on EMR. Then also the leadership of the facility, the CCC, through the in charge, Dr. Mboro, and her deputy, Susan Alomada, were appointed a champion who would be responsible to just to drive this agenda forward, and with clear terms and responsibilities, just for the sake of following through. To ensure that the line list generated, the clients being called on a timely manner, and this was being done on a near weekly basis. Then we went ahead through the support of the lab, SI team, to try and update the system. That the team, we changed how the clients were flowing within the facility. So we made sure that the link desk and the triage were flagging clients who are eligible for redirecting them to the lab first, and then later on they would go to the clinical consultation. So we also did synchronization for appointments for the pediatric groups, and also those that were for the priority population, the PMTCT, and those who are coming over the weekends, just to try and align their clinical visits with bleeding of viral load. And this is something that was continuous on a day-to-day basis. Then we identified somebody to be responsible in uploading the results on the EMR. So the TPAs agreed in terms of teamwork just to be doing this every twice a week, every Tuesday and Thursday. So every morning before they embark on their work is just to look and ensure that all the results that were sent are back and are duly updated in the EMR. This one also gave them an opportunity to flag clients that were having high viral load. And then also as a team, we instituted a line list review meeting that we were using to now check how the line lists were reducing by day, and the missed opportunities that we used to have. So we realized that it's one thing to maintain a line list, but it's another thing just to ensure that you follow through and ensure that the line list is actively being tracked. And then the last thing that also we did, the clinicians now started indicating on the patient cards the reason for visit, be it viral load or cervical cancer screening. So we normally indicate on the patient card that if the TCA has been indicated, then it's easier for the link desk person or the triage person just to identify the eligible clients and then refer them back for bleeding. So this we uploaded it directly to the CQI dashboard that we normally use from the supported partner, the Faria Jami. We have a CQI portal where we uploaded the problem and what we were doing. So this is just a snapshot just to show how we were documenting each and every milestone. So what the in charge does is just look at the activities that have been assigned, and on a weekly basis, she's able through the dashboard just to look whether the activity has been done or whether it is on track and whether it's being managed. So then she reminds the responsible person just to go and update. So these are just the sample of the milestones that we managed to capture. and document. So in terms of where we are at and looking at the trends over time by different age categories, 0 to 14, you can see where we started off at 54%, and currently we are at 98%. Then we also segregated it by the 15 to 19 age cohort, and then the 25 plus age cohort. So you can realize around January is whereby we had, before the schools opened, we called the children of them. So that's a strategy that we also use during their youth days, their fun days, and youth activities within the facility. So once they come, the first thing that we do, we just flag out those that are eligible and are due for follow-up and bleeding. This is just a performance run chart just to show you how the progress has been over time, where we started in October, and how the progress has been as we monitor, and the team gets encouraged when they see the trend line is going up. So in terms of suppression, so it's another thing that we've we also look at it closely. So we look at viral load suppression in terms of the cutoff. So we look at those that are suppressed using the cutoff of less than 50 and LDL. So currently we are doing 85%. And then those that are 50 to 199, we have 10% of cohort. And then those that are between 200 and 999, we have 2%, and those that are doing 1,000 copies, we have 2%. So we've instituted measures just to address this. And also this we are tracking through the CQI dashboard. And also we are using this in relation to the U is equals to U messaging, so that we can ensure that all our children and adults remain unsuppressed. So in terms of some of the challenges that we encountered, we at a point we had inadequate PPT tubes, but what we did as a facility, we worked with the lab coordinator and mentor just to try and redistribute commodities from low volume facilities which had extra stocks, and looking at their projections, they will not consume all of it. So, and then we redirect it to the facility just to ensure that we continue bleeding our clients. And then for the clients that were on multi-month dispensation, some of them had difficulties in agreeing to come back for bleeding, but through the health talks and phone calls, attaching them to the peer mentors, and also just using the virtual space and virtual dots, we really encouraged them, and they managed to come back for bleeding. So the other thing that and has been mentioned with in this presentation was the workload in terms of updating. The initial phase for updating, we had close to 2,000 results from the website that were not updated in the EMR, and so we just reorganized our team, how we move, and how we support the facility team, and the partner was in hand also to support, and we really distributed the results among the clinical team just to put them in the EMR, something that also was tedious but was manageable. Then in terms of the irregular school calendar, just to align for the AYPs and the clinic. Then also during that time, we implemented the lab manifest module in EMR, but due to challenges with the facility network and also some bug within the system, it couldn't pick. We used to send through the sample, but it was not picking at the testing lab. So it's something that the Palladium team is still working on. And probably it's if something that if it's they give us a solution sooner rather than later, I think we'll be at 100% and not 99%, because now we are looking at just maintaining that standard and not going back to where we are. So what the sum of the lessons that we learned along the way is that the SI clinical interface is very critical, especially using data and at real time for program implementation, and also monitoring our clients for better outcome. The other thing that we learned was that facility leadership is critical, and the good thing is even as we look in terms of sustainability, the leadership at Mbagathi Hospital is county led, so they in charge, and both our deputies are county staff. So in terms, even if the partner will disengage, so it's something that we are sure of continuity. And then also using the QI approach to improve performance has a lasting and sustainable effect on the healthcare system. And then finally is that the facilities have their own localized solutions with greater impact. So it's just the way this team sets up and looks at their data, and then they will be able just to understand how to come up with solutions through implementation of the approach. Thank you very much, and I beg to stop at that.
Thank you very much, Charles. Thanks, and more importantly for accepting to share with us. I know I reached out yesterday evening. It was very late in the evening, but we really appreciate the fact that you are able to just prepare quickly and share with the team your best practices. I know the attrition rate is quite high. People are dropping off because of time, but just kindly allow me to welcome Tumutumu. Just 2 minutes, 3 minutes to share with us their best practices. I'm not expecting them to make a presentation, but just share with us what they've been able to do also. And I guess it's more similar to what Charles has shared, but it's good to just hear from them also. And I'm hoping that the rest of the teams are also taking notes, because our expectation is that you'll be able to replicate what these two facilities have been able to do. Over to you, Tumutumu. Just 2-3 minutes, please, so that we can close this because of time. I don't know that the team is still in. Yeah, so the team is appreciating the work you're doing, Mbagathi. Fine. So, Michael, okay. So, Michael, I hope you're going to speak on behalf of Tumutumu. Just 2 minutes, please, so that we can close. Mike, go ahead, please.
You can hear me?
Just increase your volume a bit.
Okay. Am I better?
Much better. Go ahead, please.
Okay. For Tumutumu, I know they had sent their presentation to me. So let me just take you through what they did. So for Tumutumu, their issues began when they were looking at COVID 2020-2021. And what they had were clients that had invalid viral load results. And there was, at that particular point in time, there was also PPT stockouts. So what they decided to do as a facility was to line list and assign case managers to all clients who were eligible for VL and sample collection. Then an element of escorting difficult and unwilling clients to the lab for sample collection, and then conducting home visits and collecting viral load samples for bedridden clients in collaboration with laboratory technologists. Then they trained and sensitized the lab personnel on VL sample collection and remote logging of client details to reduce sample rejection. Then the other element that they did was sourcing out for VL PPT and collection tubes in case of shortage from their neighboring facilities, and then timely shipping of VL samples to NASCOP, KNH for analysis, and VL result management was also done real time, and the results given to clinicians and the tasks for action. The consequence of that was that they identified 99.5% of their clients that were eligible for viral load. Currently, they have 99% with a valid viral load in the national data warehouse, as well as in the viral load database. And out of that, the gap that they have currently is around 1% that in terms of concordance of data. Based on that interventions, they have seen an improved uptake of viral loads, and their TAT has also improved to approximately 3 days by the time they collect sample and the time they get their results back. In terms of lessons learned from their exercise, line listing and calling of clients prior to their viral load due date is of importance in preparing clients for the process. Then reaching out to bedridden clients in the community has helped avoid missing out on viral load uptake. Patient health education was equally as important since it made the clients understand the need of the viral load, and that way then there was a positive uptake of the process. Then management of PPT stocks within the facility has ensured that they no longer run out of stocks. And then the sensitization of staff through CMEs has really improved the capacity of the staff in terms of monitoring viral loads for clients. And that has really made a difference in terms of the uptake for their clients. I think that is all I can say on behalf of the team that is in Tumutumu PCA Mission Hospital, supported under the Kenya Conference of Catholic Bishops. Thank you.
Thank you very much, Michael, for summarizing on behalf of the team. So from my end, I really don't want to stretch you any longer. Allow me to just hand it over to Dr. Lily to take us through the last part, our call to action, and then we will close from there. So Dr. Lily, over to you, please. Dr. if you can hear me. Dr. Lily, can you hear me?
Yes, Sungoka, I can hear you.
All right, so I think we can close it up. So I want to just put up the slides on for call to action so that you can quickly take us through that, and we should be able to then go to the closing bit.
Okay, so as you're putting that up, we have we've listened to very good presentations. Then we allow even for people to reflect and react, which is one of the things that we are really missing out in this presentation. So before I do the call to action, because I think then this should be leading us towards closing, it would be important to just hear reflections one or two people. We have seen, we have had, I have seen a lot of comments in the comment section around, okay, MLab is this nice application. It's going to be a game changer in terms of ensuring that results are in patients' records, and we are providing, we are being very responsive in terms of tracking our third 90. So let's hear some reflections, Songok, then I can wrap it up with the call to action. We have seen some facilities that are line listing and, being very intentional about following up their clients. So one or two people, Dr. Kimanga is here. We have other partners, we have facilities. Let's just hear one or two, then we can close.
Looking out for any hand up. For the participants who have the mics, you can just unmute and probably make a few comments on what you've been able to do, and probably also just rallying calls to the other facilities and the other teams. So I can see Dr. Jonah Maswai from KDOD, Dr. Usiemo. Maybe a few comments, Dr. Ari, kindly. Yes, Doc, I can hear you.
Yes,
But
we can.
Yeah. So the use of the platforms that have just been shared, and I think I'll particularly talk about the lab manifest, has really been a game changer. We've seen this in the counties that we support, in Nandi, in Kericho, Narok, and Bomet. They've really taken up the lab manifest, and it has been something that that rewards itself. They've seen the improvement in patient care, and they've seen the ease with which they are now able to get results. And basically what I just want to say is that some of these innovations require a bit of effort, but they are self-rewarding. I have just been in a meeting with service providers, and one of the things that they really point out is how easy their work has been because of improving the uptake of the lab manifest in terms of tracking results and using them for patient care. So I just want to encourage us that a little effort might be required, but at the end, it makes things a lot easier. Thank you, and back to you.
Over to you, Dr. Lily.
Okay, so put up the slide. Thank you, Jonah. So I think this slide that I'm about to present is sort of like wrapping up the discussions that we have had. I think we have been able to pick and even just hear from facilities in terms of the efforts that are being put in place to ensure that we are tracking our third 90 effectively and being able to provide services that are, of quality to our patients. So I think one of the key takeaways is that we need to use these results that we have able to highlight where the gaps are. And one of the most important things is, one, to improve the uptake of viral load testing. So we ensure that everybody who's eligible for a test is, bled and the test is taken. Then we also need to have that documented. If you do anything and you're not documenting, it will continue to remain as having not been done. So that then we can be able to track suppression for both for all our clients, including the children. So within this PMTCT RRI, we really want to leverage the RRI to ensure that we catch up with in terms of closing the gaps that currently exist. So the viral load testing and ensuring that we are line listing everybody who's not suppressed, so that then we can be able to follow them up. And we are taking advantage of the RRI because we may have additional resources, additional support, and people are just motivated. So that then by the time we are done with the RRI, we are able to move we've already internalized this as a habit, and we now then routinize and continue to do this systematically. So we have been able to also see the applications or platforms that are helping us and supporting us in terms of improving the uptake and documentation. So the manifest and the MLab. Majority of the facilities here are using Kenya EMR, which has the MLab. So I don't know what is stopping us from using it. I think if we can commit that going forward, if we need any additional support to be able to initiate using these enhancements, either training, feel free to reach out to us and we can organize another training, virtual or otherwise, so that then we can be able to also improve the uptake of these platforms, because they're helping us to do our work and make our work much easier. So I have mentioned about developing a line list, so that then within the line list, we are able to document who is due for a viral load, and then either call, we do, the things that we do at facility level to ensure that we are able to reach this for us. So going forward, we shall be having frequent meetings, so that we can ensure that we are showcasing our performance, and being able to just go back and fill the gap, so that we can be able to support our clients to achieve viral suppression. I think, as Dr. Rose mentioned in her opening remarks, we already know what it means when a patient has viral suppression in terms of the quality of life that they're going to live. So, and that power lies in our hands to ensure that we do that for them. So I will now move towards closing. Dr. Rose is still here with us, and we really appreciate that. I think we reached almost 600 participants, and we appreciate that. I think we had overpacked the agenda. We look forward to to doing our due diligence in future to ensure that we give you bits and pieces, so that then we can be able to have very focused information. So, Dr. Rose, I want to ask you to make some remarks as we move towards closing.
Thank you so much, Dr. Lily. I don't know whether on the call we still have Brian, or Brian left. I know that Sade was there also. Okay. Dr. Sade. Nakaa ndo nilikaa sana. Am I still on the call?
No, you're there. No, we stayed. I think some people dropped off.
Yeah, I can see Dr. Sade is there. I don't know that anyone is from WHO.
Dr. Sade
from GF. Dr. Sade, maybe you want to say something? Sorry, we didn't give a chance to Global Fund.
Yeah, she didn't have a mic, but I've allowed her to speak. So Dr. Sade, you can unmute, then go ahead.
Dr. Sade? Okay. You've given her a mic.
Yes, Doc, I have. Yes, I have.
Okay, so maybe in view of the time, just to start by appreciating the team once again. I don't think I want to say anything more than what I'd said at the beginning. I think this is really wonderful in terms of seeing not just the clinical improvements that we can do to improve our outcomes, but also the system changes that are happening. I've really been excited about the phone application, the MLab, the lab manifest. I think we're going to see a very different picture of the HIV program once this is optimized, and our call is for, as Lily has said, to see that even during this RRI, we can try and push as much. I do realize that maybe we have not asked a lot about the investments and what it takes, but looks like from the discussions, these are things that can be embedded within what is currently already funded. So I think what we need to really track and ensure that this is a periodic meeting, we see how far we are going, given that now this is our baseline. Can we see, for example, in the period of the RRI, a movement of 10% improvement in the viral load uptake gap that we have seen, so that we see results that we want as a team? What I've also really picked from the, I think, Tumtum and Bagadi presentation, is that there are really very interesting small tweaks that can happen, that can really give us positive results. And I'm speaking about just hearing about them thinking about the bedridden client. what can I do? Because some of these missed numbers and the numbers are not suppressing are really very sick clients that are not able to come to us. So if the clients cannot come to us, what can we do? I think things around empowering the clients to know and demand this service when they come, because it's not a commodity issue. What can we do about that? And then realigning services to the school holidays. Remember, we are going into the school holidays. So I would like to ask the partners, the counties, to really optimize during this period, because we saw that children and these people under 25 years are really not doing very well with regard to the results. So we have an opportunity during August to really improve on this performance, so that we can see a shift towards optimizing the subpopulation that have been left behind. And my call to the SI team and to the partners and the counties is maybe to go back and sit and read us. Set your own internal targets that will build up to the national target that we really want. This is the work that has gone into this. Thank you, the team that has worked on this, even the counties and the partners. Take this as a challenge, that this is your contribution to the third 90 and that we can get to the best. I had a few questions around the systems, but I do hope we can work together to ensure that everyone is on the same page. Asanteni sana, and hopefully we can all write our stories about the good work that we are doing as we learn from the others. Congratulations, Magathi and Tumkim. I hope this can be, I'm wondering whether, Lily, it is allowed for the teams to agree on to have a CQI project for each facility, so that, because we've seen Magathi using the CQI approach to look at their own issues, just seeing that results are improved. So that is something to think about as an action from here for each facility as we move forward. Back to you, Lily.
Asante. Thank you, Dr. Rose. I think you have closed for us our meeting. So one of the that supported to put this meeting together. Of course, the Palladium.
Unakatika, Lily, at least from my end. I don't know kama ni my network.
Yeah, we are losing our audio. Dr. Lily, we can't hear you.
So maybe as she comes back,
shared in this forum.
Lily, you are katika ring. We are not hearing you continuously. Maybe you can cough and then you start speaking continuously. As you cough, I wanted to just say that I had a few questions, and I know people were asking a few questions. Perhaps in the next presentation or in the next engagement when we are discussing, perhaps we can invite the lab team to also maybe allow the implementers at the site to speak about their experiences, because I saw some of them talking about, is it possible for the manifest or the systems we are putting in to track where their samples have gone, like their needs in terms of, are they in which lab? When you're talking about the labs, are we able to just see what is being done to reduce the turnaround times, so that it is reduced, and some of the innovations around products and processes. So that is something I felt maybe we could also provide a platform to hear from a programmatic point of view. But over to you. Thanks.
Okay, so I hope now I'm audible. Songo, please confirm that I'm audible. So
Yes.
As I was saying.
Yes, you are.
Yeah, thank you. Yeah, so I was just really appreciating those remarks by the head of NASCOP. And I said that given that this was our first, a feedback session in the last 6 months, we have learned quite a bit, just as a team, especially the team that's really put this together, the Team Palladium, Team Health IT, NASCOP, SI, of course, with the leadership from the head of NASCOP, CDC, PEPFAR. So we shall sit back and pick some of the lessons and see how we can leverage these RRI, some of the things that Rose is asking about the CQI and how we can start to institutionalize them in all the facilities. So we shall come back again with some feedback. Unfortunately, we had hoped that within this meeting, we can be able to ask questions and sort of like have like a roadmap and agree on how we want to move forward. But unfortunately, time is not on our, so we shall close at this point, but we shall be getting back to you through the different forums that we reached you to also just provide some guidance. And also given that during the RRI, we shall also be doing a lot of visits to youth virtually and physically, we shall continue to engage. So having said that, I really want to appreciate all of you for staying this long. I can see the attrition is, I mean, people are starting to drop off after 2.5 hours. I think it's only fair that we end the meeting at this point. We really appreciate the facilities for the good work you're doing, the partners and the county for your oversight. Asanteni sana. Have a good evening and see you in these corridors.
Thank you, everyone. Asanteni sana. I'll be sharing the slides and also the document, the bulletin to all the teams. Thank you.
Yeah, thanks, Songok. Kwaheri.